I'd like to call upon the next speaker, Dr. Anabi. She's a senior consultant cataract surgeon and heads the uvea services at Tony Fernandez Eye Hospital, Alva. She'll be speaking to us about biologics and intraocular inflammation.
So my topic is biologics in ocular inflammatory diseases. Let's first see the principles of management of uveitis. First and foremost is control of inflammation, which is the primary goal. It can be done by induction, that is initial control with steroids, and suppression or long-term control with immunosuppressives. Second one is prevent visual loss, then prevent structural damage to the eye due to persistent inflammation. So there is a step ladder approach to uveitis management. First is corticosteroids, then we move on to conventional immunosuppressives, and finally biologics. So I'll be talking about biologics. So this is the step ladder pattern. We start the patient with systemic steroids, 1 to 1.5 milligram per kilogram body weight. And if the uveitis is not controlled in 4 to 6 weeks, we will move on to conventional immunosuppressives. If there is inadequate response in 3 to 6 months, in spite of maximum tolerated dose, we move on to biologics. And first line is adalimumab, infliximab, and golimumab. Second line is tocilizumab and rituximab. So what are the indications for immunosuppressives? When there is worsening of inflammation while on high-dose steroids, when there is active uveitis while on systemic steroids, dosed at 30 milligram or 0.5 milligram per kilogram per day, relapse of uveitis after reduction of doses to less than 7 to 10 milligram per day, and as a steroid sparing therapy to avoid the side effects, and in severe sight-threatening conditions. So what are the indications for severe inflammation? It is impairment of visual function less than 20 by 100. If it is a bilateral disease, if there is vitreous haze of more than or equal to 2, if there is macular or optic nerve involvement, when the retinal vessels are involved, macular edema and exudative detachment, ocular structural complications that threaten the visual function, if the disease is recurrent or chronic. Diseases where biologics can be started early in treatment are Behçet's disease, sympathetic ophthalmia, VKH, rheumatoid necrotizing scleritis, and Wegener's granulomatosis, relapsing polychondritis with scleritis, and juvenile idiopathic arthritis. There are certain relative indications also. It is recurrent intermediate uveitis, retinal vasculitis, severe chronic iridocyclitis, and sarcoid-associated uveitis. I'm not going to the classification. The first drug is adalimumab. That is the only FDA-approved molecule for treatment of non-infectious uveitis. It is used in treatment of juvenile idiopathic arthritis, Behçet's disease, VKH, sarcoid, ankylosing spondylitis, birdshot chorioretinitis, pars planitis, and idiopathic uveitis. It is given as a subcutaneous infection, loading dose of 80 milligram at week 0, then a dose of 40 milligram at week 1, followed by maintenance doses of 40 milligram given at 2 weeks interval thereafter. The cost is 25,000 for 40 milligram, but biosimilars are available for 7,000 for 40 milligram. Next drug is infliximab. It is not approved by FDA for treatment of non-infectious uveitis. The indications are almost similar, and the dose is 5 milligram per kilogram at week 0 to 6, followed by 4 to 8 weekly. The cost is 25,000 for 100 milligram. Golimumab, it is less frequently used. It is used in treatment of uveitis associated with Behçet's disease, JIA associated uveitis, and HLA-B27 associated uveitis. Dose is 50 milligram every 4 weeks subcutaneous, or an IV loading dose of 2 milligram per kilogram every 4 weeks, then extended to 8 weeks. The cost is 22,000 for 50 milligram. Tocilizumab, it is used in the treatment of uveitis associated with Behçet's, birdshot choroiditis, again JIA, sympathetic ophthalmia, and ocular sarcoidosis. The indications are almost the same for all days. Doses subcutaneous 162 milligram weekly or IV 4 to 8 milligram per kilogram weekly. Cost is 25,000 for 400 milligram. Rituximab, that is anti-CD20 drug, it is used in refractory Behçet's disease, JIA refractory to anti-TNF agents, ANCA-positive vasculitis, non-infective scleritis, VKH and HLA-B27 associated uveitis, primary intraocular lymphoma, and polyangiitis with ocular and orbital involvement. The dose is 500 to 1000 milligram IV 2 weeks apart, repeated every 4 to 6 months. The biosimilars cost is for 500 milligram, it is 20,000. The latest is JAK inhibitors. It is synthetic disease-modifying anti-rheumatic drug. It is available as tablets. It is used in non-infectious uveitis refractory to conventional and biological immunosuppressives. Tofacitinib is the most commonly used one. It is weight-dependent dose. If the weight is more than 40 kg, it is 5 milligram twice daily or 11 milligram extended release once daily. If the weight is between 20 to 40, it is 4 milligram twice daily. And if the weight is between 10 to 20, it is 3.2 milligram twice daily, available as an oral suspension. The cost is less, it is 1,100 for 60 tablets, 5 milligram. So how do you evaluate the patient pre-treatment? You have to do a complete blood count with platelet count. Then you have to do a liver function test, blood urea, creatinine, electrolytes, urine analysis, and uric acid. Cardiovascular evaluation should be done because some of the drugs can cause cardiac failure. The cholesterol level, you have to check BP, assess the cardiac status, and rule out cardiac failure. Then we have to rule out demyelinating diseases because infliximab is known to cause demyelination. Rule out infections like tuberculosis, HIV, hepatitis B, and hepatitis C. Inquire about history of malignancy for self and in family. Then you have to rule out autoimmune diseases because if an autoimmune disease is present, the biologics use will be different. Then you have to have an immunization record. Patients should be immunized up to date for pneumococcal, influenza, and hepatitis B vaccine. A word of caution about pregnancy till 5 months after stopping the last dose of biologics. Patients receiving anti-TNF therapy should not have live virus vaccine including varicella, oral polio, or rabies. Patient should be aware of the adverse effects of the drug and consult a doctor if the patient develops fever, sore throat, or bleeding. How do you monitor a patient on biologics? Blood workup should be done every 2 to 4 weeks for 2 to 3 months, then every 6 to 8 weeks. And uveitis follow-up should be done 4 to 6 weeks after starting biologics, then 4 to 6 weekly until the uveitis is controlled. And once stable, it is once in 2 to 4 months. What is the criteria used to decide adjusting the systemic therapy? Whenever there is a decrease in vision, increase in AC cells and flare, increase in vitreous haze, increase in the chorioretinal lesions, and if there is retinal vascular involvement or macular or optic nerve involvement, then we should think of increasing the dose. What to do if one immunomodulatory agent is ineffective? We should think about treatment non-compliance, and we have to reconsider the diagnosis, that is to rule out infection or look for masquerade syndrome. This is a 15-year-old female who came to us with complaints of floaters of 1 year duration. When she presented, the vision was 660 in right eye and 618 in the left eye. Slit lamp examination showed anterior vitreous phase cells of 1+. She gave history of taking biologics for the last 6 months, but they were not satisfied with the response. So they stopped the medication and came to us. When she came to us, the fundus picture was this feature suggestive of retinal vasculitis was present, and OCT showed macular edema. So we started initially the patient on systemic steroids. We sent the patient for a rheumatological consultation, and she was again started on adalimumab. And after 3 weeks of starting biologics, she was put on MMF also, and she responded very well. Macular edema subsided. So what is the approach if one anti-TNF is ineffective? You should escalate the dose to maximum tolerated therapeutic dose, that is increase infliximab to 5 to 10 milligram per kilogram every 4 weeks, or increase the frequency of adalimumab to weekly, or switch to another anti-TNF such as golimumab or certolizumab, or you should start combined treatment. In this patient, they have started biologics with mycophenolate mofetil, or you should think about second-line biologics. This is again a 27-year-old female. She is a non-case of ankylosing spondylitis. She is from Odisha. She was on biologics because of recurrent anterior uveitis and her systemic problem. Here also the patient stopped the medication, and then she came to us with recurrence of anterior uveitis. She was sent to rheumatologist, and now she is again started on biologic. So this raises the question when to stop the medication. Treatment has to be continued for 2 years after the disease is inactive, and interval between the doses is increased and then slowly stopped in 12 months. Suppose the patient is on combination with the anti-metabolite, then we have to stop the anti-metabolite first and then the biology. So it is a shared decision making. Ophthalmologist makes a diagnosis, comes to a differential diagnosis and do the investigations. We make a preliminary diagnosis. We do the local therapy and the ocular monitoring. When we send the patient to the rheumatologist, they will rule out systemic diseases. They do further investigations and manage the systemic drug therapy. So to summarize, a symptomatic patient while on biologics, if there is no response, we have to rule out infection and masquerade, and it can be either a primary non-response or a secondary non-response. If it is a primary non-response, we have to switch to a different class of medication. If it is secondary non-response, we have to do a dose adjustment or add other immunomodulators. If these two are not effective, then we have to switch within the same drug class. Thank you.
Thank you, Dr. Anabi, for that nice overview. Uveitis is, biologics are used extensively in uveitis and has really changed how it is